Hi, this is Mrs. White, and today we are going to talk about the difference between hyperthyroidism and hypothyroidism, including some of the nursing care. We're going to start here with hyperthyroidism, and as always, we're going to be using Next Gen. So remember, Next Gen wants us to be able to recognize and analyze cues. It wants us to be able to form hypothesis, right? So our priorities, what's most pressing, what are complications, what happens if we do something to fix it, what are the complications of that, and what if we do nothing? Generating solutions and taking action. That would be our nursing interventions, our evaluations, ethical concerns, and then also we have some diagnostics here and medications to know. So let's talk about some of the cues. So things in past medical history, things that we may see, risk factors that would lead you to believe somebody has hyperthyroidism. In general, hyperthyroidism affects females more than males. Your typical patient will be a female between the ages of 20 and 40 years old. Graves' disease is the most common, which is an autoimmune disorder. Other possibilities that could cause hyperthyroidism would be thyroiditis, too much iodine intake, pituitary tumors, and thyroid cancer. Some of the signs and symptoms you might see would be an enlarged thyroid, also called a goiter. So remember, with a goiter, we'll bounce over here to hypotheses. We could have laryngeal nerve compression. That could be an airway issue. So anytime we have a goiter, we want to be concerned about the airway. Okay, so there may also be a bruit that could be heard over the thyroid. In general, people with hyperthyroidism and thyrotoxicosis, which is the clinical manifestations of too much thyroid hormone, they have signs of increased metabolism. So what are those? Those are increased heart rate, increased temperature, increased blood pressure. They may be agitated, increased respiratory rate, emotional lability. People who are suffering from hyperthyroidism tend to be very emotional, very labile. They may experience exophthalmos, which are those bugging, protruding eyes. Their hair may be thin and have hair loss, very, very thin hair loss. They may have dyspnea on exertion. Weight loss is a big trigger for us. Weight loss, even though they have an increased appetite. Remember, these people have increased metabolism. Thin and brittle nails. They may have reproductive changes, including amenorrhea. And these people, they may have increased deep tendon reflexes, osteoporosis, and heat intolerance. So how do we diagnose this one, huh? So we look at the TSH. In general, the TSH is undetectable or low if it's a thyroid issue. And then we see increased T3 and T4, but especially T4. We could do a radioactive iodine uptake test. So in that case, we give the person a small dose of iodine that's been radioactive in a capsule, and then we wait, and then we scan their thyroid to see how much is taken up in the thyroid. An EKG might tell us that they are tachycardic. Something I'd like to mention here is in the case of somebody who has hyperthyroidism, under prioritizing hypothesis, one of the biggest risks they could have would be a thyroid storm. A thyroid storm is a life-threatening complication of hyperthyroidism. I consider the thyroid gland to be like a very volatile balloon full of thyroid hormone. So if you know your patient has hyperthyroidism and you start to manipulate the thyroid, what you can do is actually release so much thyroid hormone into the bloodstream that you can cause a thyroid storm. So that would be a major risk. So what would we see in a thyroid storm? Definite elevated temperature, tachycardia, patient could be agitated, anxious, which could even lead to delirium or even a coma, hypertension, and heart failure. So if we know that's the signs and symptoms as we go over to medications, that's going to help us understand why we give the meds we do. Some of the other problems that can arise from hyperthyroidism would be risk of the adverse effects of increased metabolism, right? Impaired nutrition, less than body requirements. And then, of course, if we're doing any sort of surgical intervention, we could have the risk factors related to surgeries. So we'll talk about those. So, under generating solutions and take action, we want to give the person relief of signs and symptoms. We want them not to experience any serious complication, maintain their nutritional balance, and then be able to comply with the therapeutic plan. So, how do we do this? So, we need to definitely monitor for the thyroid storm. Remember, they could be tachycardic, experience heart failure, signs of shock. Their temperature can go as high as 106 degrees. They could have seizures. We want to give the person who has hyperthyroidism a high-calorie diet, avoiding stimulants, right? These are not the people that we give them coffee on their tray. They're already stimulated enough. Medications as ordered, which we'll talk about down below. We could do some radioactive iodine therapy, which for that, radioactive iodine therapy, the person cannot be pregnant, so we'll want to make sure that we do a pregnancy test on females or those whose gender assigned at birth is female. This could be a delayed response to the radioactive iodine therapy, so the person will need to keep taking antithyroid medications for 3 months. It's done as an outpatient. The person does need some radiation precautions, especially with the urine. And as I tell you guys often, every time we treat something, we can cause the opposite problem. So we can give a person treatment to treat their hyperthyroidism, and we can cause hypothyroidism. Why it's very important to know the differences and to keep that always in the back of your mind, that that could be a potential complication of a treatment. You want to do good oral care on these folks who are getting radioactive iodine therapy. Exophthalmos. So what do we do with those buggy eyes, guys? Well, artificial tears, sodium restrictions, elevating the head of the bed, dark glasses. We may need to tape their eyelids when they sleep. So again, they could have some ocular complications. Surgery. So the surgery that we prefer to do is a subtotal thyroidectomy. That's not always possible. Sometimes they need a total thyroidectomy. So subtotal, they don't always need lifelong thyroid replacement. Total, they would. And remember what's hanging out with that thyroid, right? It's our parathyroids as well. So it's often that they are injured or removed right along with the thyroid. So post-op surgical of the thyroid surgery, thyroid removal, either partial or total. What do you think your main concern will be post-op for somebody? Think about where the thyroid sits, think about where the incisions are, and what the complications could be. Hopefully you're saying airway, right? So airway is an absolute problem. So we want to make sure that we're doing all of our interventions to maintain an adequate airway. So that would be making sure the person is sitting up, supporting the head and neck. We also need to check for bleeding, of course, so we'll monitor for that. Less of a complication, but always a potential. Hypocalcemia would be the other big thing to monitor after anything to do with thyroid removal. So hypocalcemia. So how do we know somebody's got signs and symptoms of hypocalcemia? They could have stridor, that would be a very late sign. They might have trousseau and Chopstock sign. Numbness and tingling around the mouth, that's going to be an early sign. Somebody complains of circumoral tingling. How do we treat it? What do you think you always have to have on hand to treat hypocalcemia? Hopefully you said give IV calcium, right? We want to have IV calcium available. All right, some of the other complications could be laryngeal nerve damage, thyrotoxicosis. In fact, we often will have to have the patient undergo some treatment to radiate or decrease the activity of the thyroid before we consider removing it. Infection is a later concern. And then undertake action. We always want to be aware of how we treat acute thyrotoxicosis or the thyroid storm. These patients require ICU level of care. Let's say you did have signs of acute thyrotoxicosis. Basically, for us, it's a post-op, a lot of supportive care. Oxygen and IV fluids are needed until the thyroid sort of wears off. But now as we go down to some of our other medications to know, let's talk about this. So actually, I want to back up a little bit. Somebody with hyperthyroidism, some of the easy nursing measures we could do is keep them in a cool, quiet room. Light linen coverings. Remember, they have increased metabolism. They're going to sweat, so we might need to change their linens more often. When we talked about diet, high-calorie diet, avoiding stimulants, that's 6 meals a day, including snacks, 1 to 2 milligrams per kilogram of protein, and increased carb. So under the medications, one that we're going to talk about is SSKI, which is saturated solution potassium iodine. So that basically, we use that prior to surgery to decrease the vascularity of the gland, make it less likely that the person would experience a thyroid storm. Takes 1 to 2 weeks, and again, so that's the use of that. Antithyroid drugs, methimazole, tapazole, propylthiouracil, some of the most common meds. So we could use that for a thyroid storm as well, but it's also to their antithyroid drugs. We see improvement in the patient within about 1 to 2 weeks, but pure results are 4 to 8 weeks, and they're on treatment for that for 6 to 15 months. Can't be pregnant while taking that. So remember, while we're doing some of these other treatments, they're on the antithyroid drugs. So side effects would be dryness, irritation of the mouth. When we're using these antithyroid drugs, remember to flush the toilet 2 to 3 times, separate laundry, and avoid pregnant people and kids for about 7 days. We could use radiation. And if we were to use radiation, the person would need radiation precautions. And iodine, radioactive iodine, is very upsetting to the GI tract. Propranolol, beta blockers. I want to take a special moment to talk about this. So beta blockers, those are our drugs that end in LOL. They block the sympathetic nervous system, and they work rapidly. Remember, somebody with hyperthyroidism, some of the signs and symptoms look like they're having increased sympathetic nervous system, right? They are, because of the thyroid hormone. So we give beta blockers. They work rapidly. Radioactive iodine therapy, I know I mentioned it already, but it's the treatment of choice for non-pregnant adults. Can take up to 3 months. We need to keep them on their other meds until then. And again, that's the one that we want to double flush with. So radioactive iodine therapy. Not so much with some of the others. And then hypophysectomy. Why would we need a pituitary surgery for hyperthyroidism? We would need it if the problem wasn't with the thyroid itself, but instead was with the pituitary. So remember the surgical interventions for hypophysectomy. If you don't know those, I want you to go back and watch the video on the pituitary disorders because we talk about it there. And just one more little thing. Anytime we're giving a medication, we can always give too much, right? So if we're giving iodine, a medication containing iodine, we could give the patient too much iodine. If we're giving the patient beta blockers, we could give them too much beta blockers. So you need to monitor for the side effects of these medications. So what would be some of the signs that somebody has iodine toxicity? Swelling, mucous membrane salivation, nausea and vomiting. That would prompt a call to the doctor, right? I'm not going to give something if I think they're having too much of it already. Give a call to the doctor and let them talk about it, right? Off your shoulders onto theirs. Beta blockers, if they're bradycardic and hypotensive, do we need to talk to the doctor? Absolutely. Okay, so we're going to move on to hypothyroidism now. And so there that is for you. So hypothyroidism is a thyroid deficiency that causes slowing of metabolism. Just like hyperthyroidism, it can be primary or secondary. So primary could be due to the gland itself, secondary due to some other cause like the pituitary. One of the biggest causes of atrophy of the gland is Hashimoto's, so you'll often hear that. Can be caused by an iodine deficiency, or remember, if we're treating hyperthyroidism, we can cause hypothyroidism. So clinical manifestations here. It's more common in women, white women, advancing age, people who already have an autoimmune disorder, anybody with a family history, if they have a goiter, history of radiation to the neck. So what will we see? Signs of decreased metabolism. So these guys are low and slow, right? These are cold, sedentary looking people. Bradycardic, gaining weight. The problem with a lot of our disorders is that they have very nonspecific symptoms, and hypothyroidism is one of those that starts very, very nonspecific. So gradual onset, but then as the disorder continues, the person tends to experience more and more symptoms. They're tired, lethargic. They could have an impaired memory. Remember how important it is to check for weight changes and baseline. Constipation, decreased cardiac contractility, decreased cardiac output, increased cholesterol and triglycerides, anemia because of depressed bone marrow activity. And again, these people are intolerant to the cold. Folks with hypothyroidism have increased sensitivity to barbiturates, anesthesia, opioids. So because of that, under nursing care, we want to avoid those medications. All right, so how do we diagnose it? A lot of labs, right? We look for their T3 and T4. Those are generally low. They may have a T4 antibody. TSH may be high if it's primary or low if it's secondary. But in general, our hypothyroid patients, we will speak in generalities here. In general, increased thyroid stimulating hormone. Why? The body senses it doesn't have enough. So if the pituitary is functioning, if that's right, if it's a problem with the thyroid itself, the pituitary is going to call for more. So it's going to increase that TSH. Increased creatinine kinase. All right, so hypotheses. So what are some problems, right? Big problem. So signs, the myxedema coma would be the biggest complication. And this can occur at any time to a person with hypothyroidism, though it's often occurs after they withdraw medication, or maybe they get older, they start forgetting to take their medication, or following an acute illness. They're at risk for imbalanced nutrition more, and they could also have some activity intolerance, right? So myxedema coma, we need to constantly be monitoring for that. So what will they look like? They would have impaired consciousness, low temperature, hypotension, hypoventilation, cardiovascular collapse, generalized edema. And then the treatment, of course, they need ICU level of care. They may need ventilator support, and we need to replace their thyroid hormone. So in general, under the generating solutions, for this, we generally put the person on lifelong thyroid replacement. So levothyroxine is the most common medication that you will see. And so that medication to know is there. So levothyroxine. Levothyroxine can cause dysrhythmias. So you need to be very, very careful with people who have known cardiovascular disease. Doctor orders it, you see some reason that they have some sort of cardiovascular issue, you're going to need to talk with them before you give this. Levothyroxine is taken in the morning on an empty stomach without other meds. And you want to avoid too much iodine. Right, some of the other issues, a person could become constipated, so these folks need to be on a high fiber diet, may even need a stool softener. And remember to avoid sedating meds. The patient is low already. So not too much to talk about under hypothyroidism. Remember, the biggest complication is myxedema coma. Be on the lookout for that guy. No levothyroxine. Reasons to give it, reasons to hold it. And you'll do well. All right, that's the end of the thyroid disorders.